Okay, hi, good afternoon. Welcome to the wrap-up interview in TCTAP 2024. And now we just finished the session of the mitral and tricuspid therapy. And there was a good lectures and very excellent discussions. And there are three lecturers from the session, and then we want to interview about the more things that was not discussed in the lecture. And first, we will begin with the mitral therapy. Yeah. The first question that I want to ask to Kubo and Kim is that what are the challenging anatomies for mitral tear in a real clinical situation? And how can we perform it successfully, especially in commissural region and multiple clips?
Okay, so thank you for your question. And I think that the most of the anatomy can be treated with the TIA procedure using the Pascal or the mitral clip device. But the most challenging case is mitral stenosis. Already the patient has a very small valve. Yeah, we cannot put the device in the valve. And also there is some the degeneration, including the calcification, is one of the challenging anatomy to put the device, and also the leaflet, both the leaflet calcification and the annular calcification, both are the challenging. And also you question about the commissural.
Commissural.
Yeah, commissural region is a very it's a difficult, always difficult. So you know just the A3P3 and the A1P1 is now is not challenging, but I think the posterior commissural leaflet and the anterior leaflet, commissural leaflet as isolated prolapse is very challenging. So we have to consider the fit orientation is good for the commissural region, and we have to identify the leaflet so we can grasp by the device.
Then do you prefer the smaller one for the commissural?
Personally, I prefer the long but narrow size. So
XT, like,
yes.
Yes.
Yeah, I think it's very important issue
Yeah.
for the mitral clip and other tear procedure, because in Korea right now only tear in mitral clip the system. So especially for the commissural region, it's very important to avoid the complication, because they are a very crowded area of the code. So I think at first we should check the imaging in detail. So the interaction with the imaging specialist is very important. So, and then we just target lesion and trajectory and perpendicularity, and before introducing the device into the LV, so this is very important. And then going into the LV and just pull back and just grasping. So I think it's very, we should do the procedure straightforwardly and without any other maneuver in this situation.
Great. So the second question is also for Dr. Kubo and Dr. Kim. And we have different types of mitral regurgitation, including degenerative, and within functional could have be atrial functional MR or ventricular functional MR. Is there different techniques to tackle different scenarios? And is there any precautions and things that we have to be very careful during the procedure when we encounter these anatomies?
Yeah, I think the procedure is very similar regardless of the types of etiology of the mitral regurgitation.
Yes.
But especially I'm focused on more functional MR. So in this case, I think there is a little the pathology of the valve leaflet itself. So one of the important thing is just we get a light coaptation line. So that means the perpendicularity is very important in my mind, rather than primary MR. But just the primary MR is just we close the maximal jet area, even though there is some exact the light the perpendicular line, we can reduce the MR. But sometimes when we apply the functional MR, then we after grasping the leaflet, then sometimes the MR is increased in other side. So I think we have some caution to apply the tier system for the functional MR.
Okay. I think the most of the previous study shows that regional MR, even the moderate MR, is a risk of the adverse outcomes. So we have to reduce the MR as much as possible. So especially in the primary MR, you know that if there is a tiny jet, but there is some billowing or prolapse is a residual after the procedure, it is a risk of the recurrence MR. So we have to cover the billowing or the prolapse by the device in the initial procedure.
Yeah.
And also so in the atrial functional MR, I think the procedure is not so different. But you know that the atrial function MR is a leaflet is not enough for the angular size. So I think that there is some risk of the leaflet tear or the leaflet adverse events. So we have to care about that, especially in the atrial function MR.
Yeah, I think it's already fully agree with his opinion because especially atrial function MR is that the main pathology is enlarged mitral valve annulus. So when we grasp the mitral both leaflet, then there is a possible increase of tension. So which means there is some another possibility to tear when we apply especially longer clip. So I think we should caution,
Yes.
and just close very slowly and check the position. So I think this is another important point, for the atrial function MR.
Yeah, actually, we learned a lot from the lectures that you gave us just now. It's also highlight a lot of tips and tricks in different scenarios.
And the next issue is that the device selection. Still in Korea, only metal clips are available, and maybe the Pascal will launch this year or next year. But in US and Japan, the two devices are also available. Then I want to ask you two guys about that. What is the difference and the clinical good indications for each devices? Phil, please.
Well, there's a lot of overlap between the devices. I think that in many cases, either device will work very well. There's a little more selection and size for the mitral clip, and it works very well in the middle, A2P2, especially with degenerative disease. It's the only one that's indicated for functional MR, and we use it exclusively for that. We don't use clasp for functional. As was mentioned earlier, one of the problems with functional is that you get, because it's along the entire length of the commissure, oftentimes it's hard to be specific about where to put the clip. So you put the clip in the worst place, and then the jet moves, and you have to put a clip there, and the jet moves. So you have to be very careful about your selection and your assessment after the clip has been placed in functional MR. And as we talked about, not tensioning the leaflets too much. We don't use a lot of XTWs or XTs in the functional patient. But I think one of the advantages that clasp has, and I say this not just because of my experience in mitral, but also in tricuspid, has much less interaction with the chords. It's much easier to get out of the problem once you have a chordal problem. So you can elongate and get out very easily. So I would find that especially in medial commissural flails or degenerative disease, that I would probably favor an ACE device in that situation, because I think there's probably less chance of getting stuck in the chords. But in general, they're both very good. We talked a little bit about valve area, and I think that sometimes the clasp, the larger device, maybe actually paradoxically better for valve area, but that's yet to be proven, I think. I don't know what you think.
Yeah. So this year, in Japan, the Pascal device is approved. So, but approved for only the primary MR. So that's why my case is all cases are primary MR. So all cases I use actually the Pascal ACE device. So it is a little bit narrow compared to the P10 device, but the arm is a clasp is longer than the P10 device. So I think it's very good because I like that the paddle and the clasp is the same width. It's gonna be the much it's gonna be the much leaflet tissue compared to the mitral device. And also I like the nitinol device. So it's a very flexible and safe for the leaflet. So I think it reduces the risk of the leaflet injury. And also I like the guide catheter sheath. So you know that in the mitral clip, sheath is very tough to sometimes tough to insert the groin and also the septum. But Pascal cyst is a very soft and smooth to insert the groin and also septum.
Yes. So the next question is, we know there are a lot of difficult anatomies for clips, and we know there are some limitations. In some patients, we really want to think about alternative therapies, not focus on repair, but replacement. So what is your threshold of treating very challenging anatomy with clips, maybe sometimes partial success results or not ideal results, but would you start earlier to work up for transcatheter mitral valve replacement? What is your threshold and decision-making process for this? I can answer.
Yeah. We have our experience. My experience with replacement is largely with the Medtronic Intrepid valve, and the Intrepid valve has just been redesigned. It's a lower profile now, and it actually will likely have less exclusions than it had previously. But up until now, exclusions were about 70 or 80% of the patients who were submitted for consideration, and that's a problem, right? Because you're excluding a lot of patients who need the valve.
Yes.
But I will say that we've done a transseptal 29 French now, and the valve performed very well. The valve replacement, I think, is best for MAC, severe MAC, where there's a lot of retracted posterior leaflet, where valve area can be limited. I think that's a very good scenario for valve replacement. The LVOT outflow tract issue has to really be respected.
Yes.
And sometimes, even though it may be better for a replacement, we tend to go back to the TEER because patients are not an operative candidate. And even if we can get a suboptimal result in a very elderly patient and keeps them out of the hospital with heart failure, that's a good thing. So sometimes we'll take a less than perfect result, even though we know that it's not an ideal candidate.
Yeah. So what is your
Yeah,
comment?
I agree. I totally agree with that.
Yeah.
So I think that if I think that the atrial function more is if there is a huge gap in the atrial function more, I think that one of the challenging anatomy to obtain the optimal result by TEER. So I think that the replacement therapy is a good option for this anatomy. But that the Asian patient is a very small heart. I cannot imagine that we can put the mitral valve without LVOT obstruction. So I think that the next challenge is how to overcome the LVOT obstruction after the valve replacement. So there are some tips and tricks to cut the anterior leaflet where the simultaneous septum ablation. As there are some tips and tricks now investigated. I really expect this in the future.
So in the future, I think we need more advancement for this mitral valve replacement.
Yeah.
There's a
device.
lot of mitral valve replacement therapies coming down the road. I think you're going to be happy with many of them. They're in development now. Yes.
The era of the treatment of the valve therapy is totally changing. It's very hard to follow.
Yeah.
And let's move to the tricuspid valve. And someone called it the forgotten valve, but it's now one of the hottest topic in the interventional cardiology. And recently, the FDA approved the TriClip, and in Korea, we are also looking forward to introduce it in Korea. Maybe it will be available next year in Korea. And what are the real challenges performing the TEER for tricuspid valve in your experience?
So in Japan, the approval studies are already finished last year. So I performed some cases. I hope so because the FDA approved already approved. I hopefully approved the TriClip next year Japan. So the most the challenges of the tricuspid TEER is the imaging. So imaging is very tough, and especially in the initial stage of the procedure. So actually the imagers very have trouble to do the TE, but operators are waiting to get a better image. So I think the most challenging is the TEER is imaging, and also the triluminate trial, also Japanese trial excluded the very huge gap of the huge gap of the patient. So the more than 7 millimeters gap is excluded in the trials. So it's a really challenging to put the device in the huge gap, the leaflet with a huge coefficient gap. So it's a I think that it can. I don't know. It can be treated by the tear. So we need some replacement therapy.
Yeah, I would agree about the imaging. It's a major concern.
Yeah.
In my tricuspid tear procedures today, I use both ICE and TE to complement the imaging because I think that TE sometimes can give me everything I need, but many times I need the ICE to step in when the tear is giving me difficulty. I can't see leaflet insertion, things like that. So actually what we do today is we park the TEE in the transgastric view so we can see the orientation and we can see the location of the valve, of the clip. And then we use the ICE catheter for insertion. And that actually works very well. If we use the Phillips device, we can flip back and forth on the same console. And that's been very helpful for us.
So that ice catheter is 3D ice catheter.
3D ICE catheter with NPR reconstruction. It's very
4D ice is very helpful because the home view of the ice is just a tricuspid valve. So we can explain the tricuspid valve and obtain the grasping of view of the tricuspid grip.
Right. The other challenge with tricuspid tear is that you said about the coaptation gap, but also only about 50% of tricuspid valves are actually 3 leaflet. The rest of them are 4 or 5, multiple leaflets. And so if you get into a situation where there's a very small leaflet that you can't grasp easily, that becomes a problem, especially if there's a lot of cords associated with that leaflet. So those can be some of the challenges in the tricuspid tear. Yeah.
And for tricuspid regurgitation, and most of the time it's functional, it's more on the annulus that dilates.
Correct.
And we are working on the leaflets. So there, we have some other things that could be potentially be kept in our toolbox, like the cardio band that has been mentioned.
Yep.
And also there are other options if it cannot be repaired, should be replaced. For example, EFOC that's been highlighted in the lectures. And also there are options like the heterotopic implant of valves and SVC and IVC. So is there any flow chart that how you decide which to go to which, or sometimes maybe combination, maybe what is your algorithm of helping those patients?
Right now we're still in the experimental phase and we have some approved devices, but they're just now coming on the market. So I think we're still developing those algorithms. It's a very good question. I think for patients who have pacemaker wires that are interfering with the leaflets and that are adhered, that's a better potential patient for the replacement therapy. In general, as I said in the session, I don't tend to start first with the replacement because I think infection, thrombosis, failure, those are all real issues. And I think that we don't know yet. We're only 1 year into this trial. We don't know yet how this valve is going to perform at 5 years, 10 years. And so I think it's important to be a little bit careful about who we implant, but they're definitely going to be replacement patients. I think the Cardioband to me is still very interesting. Someday I think it will be a combination of Cardioband and tear or Cardioband and replacement. I think I can see that happening fairly easily. We're involved in a heterotopic trial as a single device which attaches in the IVC and SVC and has open flaps in the atrium called the trilium. We have not yet implanted one there, but I think that'll be for patients with exclusions for repair and replacement, bad RVs, because you allow the RA to continue to be a capacitance for regurgitation, and so you're not overloading the RV immediately. So I think this is going to be very interesting. In 10 years, 5 years, hopefully we'll have an algorithm. You know?
So on one hand, we want to treat patients early because we know sometimes we're treating patients too late, but sometimes technology are not there yet. It cannot be generalized to be used in a certain country or region. So sometimes have to make kind of compromise.
That's
and
correct.
Sometimes we implant clips, but without very good reduction, but that precludes transcapular replacement. So there's a very complex algorithm. So we look forward to have your
One of the
opinion.
nice things about tricuspid disease, especially with the tear and the Cardioband, is if you get a reasonable reduction in TR, it doesn't have to be perfect, but patients feel a lot better, and the RV tends to respond to the reduced overload volume by getting smaller, getting stronger, and everything actually gets a little bit better because the annulus gets a little better. So it's interesting.
Yeah.
Yeah.
So it's definitely a very interesting and exciting area, and helping our patients we have to treat them timely, but we have to select the best strategy and device for our patients. And thank you very much for Dr. Kubo, Dr. Kim, Dr. Gray
Yes.
to help us and the lectures. And we also have the inside story. Throughout the discussion, we learn more. So thank you very much.
Thank you.
For doing as well.
Thank you.
Thank you very much.
Thank you very much.